has it, doesn't spread to the next person. So this entails clinical management of cases, of course, follow-up until they meet discharge criteria, and then identification and quarantine and follow-up of all their contacts, and testing whenever they are symptomatic during the quarantine process. Infection prevention and control is also a critical part of this, especially in important settings, which at the very beginning, back in February, March, was only the airports, and then we added the land borders, and then it started becoming a problem in healthcare settings, so it intensified infection prevention activities in healthcare settings as well. And then lastly, risk communication. So these components have been the overarching idea for the Malawi national response. So as you know, the major intervention for managing COVID-19, considering that it is a droplet infection that can easily spread from one person to the next, the major intervention so far has been physical distancing. Physical distancing is graded in several levels, as you can see on the screen, depending on the stage of the epidemic in your country. So this is how the original plan looked like to have all those levels, where the first level is how we started with rotational work schedules, managing the borders with transit vehicles, and ensuring the self-quarantining of returning travelers and restricting gatherings. And then as the epidemic gets worse, the idea was to increase gradually. And the very final level of physical distancing is a countrywide lockdown. So far, we have been using level 1 measures, which were declared back when we had no case yet. So the president declared a state of national disaster on the 20th of March, put in a stay-home order and rotational work schedules, closed schools around that time, banned mass gatherings, limited all public gatherings, and reduced capacity on public transport. So in health systems terms as well, the declaration automatically reoriented the response structure. Originally, the response structure was happening from Ministry of Health. So after the declaration of a state of national disaster, COVID-19 became a national disaster, moving all epidemic management to a cluster-based system surrounding the Department of Disaster Management, which I'm showing here. So I'm saying it's a cluster-based system because at the bottom there you can see the response clusters. You can see 10 clusters there, which I describe here on the top right corner. And considering the unprecedented nature of COVID-19, you can imagine the demand it has on resources. So all those clusters with their self-explanatory names need to be involved for an effective response. So on top of these clusters is an intercluster coordination committee, where principal secretaries of departments involved in these 10 clusters meet and make decisions. And then above that, there are two committees, Humanitarian Response Committee and Humanitarian Country Team, and it goes all the way to the president of the country. The part that has changed is what is the visible leadership of the epidemic management. At first, it was the Interministerial Committee on COVID-19. It was being chaired by the minister responsible for health. And then next, this committee, may you all mute your mics so that everyone can hear the presentation. So the Interministerial Committee on COVID-19.
It's my headphones. The problem is my headphones.
May you all mute your mic? So the Interministerial Committee then evolved to become the Presidential Task Force. At this point, the first public health trained leadership was employed to lead the epidemic when it became the Presidential Task Force. And recently, this has been rebranded to become the Presidential Committee on COVID-19. The Presidential Committee now it looks like we are now going towards the understanding that we're going to have COVID-19 for some time. So the Presidential Committee is going to have a physical secretariat in the office of the President and Cabinet. And the chair of the Presidential Committee, there are two chairs. One is a minister responsible for health, and the original chairperson of the Presidential Task Force, Dr. John Puka. Just to give you a little bit more about the health cluster, it has 9 subcommittees, and as you can see, surveillance is the engine of the epidemic management. We have clinical management, we have diagnostic services, risk communication, infection prevention, and supply chain resource mobilization, infrastructure and innovations, and of course, the money budget. At district level, this national structure is represented by the leadership of the district commissioner, who heads the district protection cluster, protection committee rather, which has several clusters reporting to it, similar to the national level. Of a lot of presence is a district health cluster, of course. And then below the district protection committee, there are supposed to be area protection committee and village civil protection committee. So these lower committees have not been very active during the response so far, but they're important levels, which hopefully we're going to start utilizing as we go forward with in the epidemic. So on the 14th of April, I should say there that the Minister of Health declared a complete lockdown. I wrote President there, but it's the Minister of Health declared a complete lockdown, which was targeted to start a few days from that day. But the courts stopped the nationwide complete lockdown upon being moved by the civil society. The civil society arguments were that there was no social protection guarantees for the poor, and the legal argument was that the minister had no legal mandate to order a complete lockdown. So this has stopped any further restrictions on human movement. So we have not had the complete lockdown ever since the court stopped it. Looking into the details of the declaration, however, they seem to have a mix of level 2, level 3, and level 4 restrictions, not necessarily a complete lockdown. So we were probably going to have a mix of those 3 levels at that particular point. Although we're saying that we've just had level 1 restrictions or level 2 restrictions, we really haven't had a lot of observation of those restrictions, except the mandatory things like stopping of educational institutions from operating. The other activities which were asked of the population were not completely adhered to. In particular, perhaps was the unstable political climate that we had at the time, and where COVID-19 became the center of the political battle, and there were a lot of misconceptions coming out from different camps of the political divide. So risk perception essentially during that period was really down, and there were a lot of transmission favoring events during that period. There were demonstrations, there were political campaigns, and of course we finally had presidential elections. political stability has sort of retained now, and there's positive movement on the on political will. And with the introduction of several interventions, what we've seen so far that is rising on the streets now is use of masks, especially on most government premises being mandatory now. And we've also had some high-profile cases, not good to have such, but that has also helped raise the profile of the disease nationwide, with people now realizing that it is a disease that is among us and we need to change. I should say that face masks is something that we need to work hard on. We have not fully utilized them, but we're taking shape. And limitations on public gatherings, we have not fully adhered to the guidance. So all the interventions so far, we have not fully enjoyed their benefit. But now we hope that we should now start focusing on those, pick up these small pieces and get them into a strong epidemic response. Of particular interest in the local communities is the shielding of the population who are at high risk of severe illness and death. We haven't done much of this, but it is something that can help us reduce our risk for mortality. And then we also need to strengthen our treatment centers. Ben will be talking about management of COVID-19, and you get to understand why we need to do a little bit more to strengthen our treatment centers. Our really strong treatment centers are perhaps the Blantyre one, because it has good oxygen supply from a plant that was recently donated by the Malawi Liverpool Wellcome Trust. Lilongwe 2 is probably going to get there with a new oxygen plant. But we need to do that for almost all central hospitals to have a robust clinical response. And then we also need to work very hard on living with COVID-19. We need to have a roadmap to coexistence with the disease. We need to retain all other clinical services so that we don't lose lives because we have COVID-19 taking up all our resources. We also need to ensure that we have a plan that leads towards the reopening of schools as well as the economy in general. So those are things that we need to look forward to. The other area that we should be working very strongly on is on our data. We need a stronger surveillance system that can accurately tell us where we are in terms of the epidemic. A lot of research activities going on, so hopefully this is going to improve. But of course, the national response also needs to invest more in surveillance. Because the current case numbers that we see are most likely an underestimate because they are based on a biased population of travelers, frontline workers, and very sick people presenting to health facilities. So this cannot give you a full picture of the epidemic size. So once we know this and the transmission dynamics, we can have a better idea of where we are. I'll now hand over to Ben for the clinical bit.
Thank you very much, Titus. So my name is Ben Morton. I'm an intensive care doctor from the UK. I've been in Malawi now for a year. We've been concentrating on the clinical side of things here. This talk is split into two sections. The first section is just to understand the disease itself, and then the second section talks about evidence-based treatment options for COVID. So to begin with, I think when COVID first emerged in China, there was it was a completely unknown entity. And since then, there's been huge numbers of research papers published about it. And so we understand much more about this disease. And the principal difference between a COVID pneumonia and a typical pneumonia is that it affects the whole lung. Okay, so a normal bacterial pneumonia tends to affect one part of the lung, whereas this is a diffuse inflammation of the lungs that affects the whole lung. The virus gets into the body via cells which are in the alveoli called the type 2 pneumocytes on a receptor called the ACE2 receptor. The disease has a slow evolution. So people feel like they have chinfini for 7 days or so, and then they either get better, or unfortunately, some patients, the minority of patients, can start to feel worse. And this is due to hypoxia. So there is development of clot in the capillaries, the smallest blood vessels around the lungs, and the blood therefore cannot flow past the alveoli. The amount of clot increases, and this then forces the right heart to work much harder than it normally does. And this is a problem, especially for people with pre-existing conditions such as ischemic heart disease and respiratory problems, who are unable to compensate for the increased work that they have both on their lungs and on their heart. This is the last complicated science slide. So what's going on is that when the virus gets into the cells say, I'm not very happy, and they recruit immune cells called macrophages. Those macrophages in turn say there is an infection here, and they activate and release lots of inflammatory and coagulant agents into the bloodstream. And these get into the capillaries. The capillaries are the smallest blood vessels that surround the alveoli. And this, unlike other viral pneumonias, triggers what we call an immunothrombosis. So the immune system propagates or causes clot or thrombosis to occur in the capillaries. This then causes infarction or death of the alveoli, and then in some occasions can cause bleeding into the lung itself. And because of the clot, it causes high blood pressure in the lungs. The lungs usually have very low blood pressure, that's normal, but as the blood pressure increases, the right side of the heart has to work harder, and that causes a problem. So if we look at the natural history of the disease, it takes about 5 days on average. It's different for different people, but on average, from being exposed to COVID, it takes 5 days before symptoms develop. Unfortunately, you do become infective, it seems, before the symptoms develop. So for about 24 hours before you get symptoms, you can be infective. And that is why sometimes screening for patients with just a temperature can sometimes give false reassurance that they aren't infective. After the onset of symptoms, the most common symptoms people have are fever, cough, and shortness of breath. I'll talk about those in more detail later, but those are the 3 most common symptoms that you will see. The average, so this is different again for different people, but the average time is then you have this kind of illness, this flu-like illness for about 7 days, where predominantly you have a cough and you have a fever. Having a runny nose does not seem to be part of having COVID. So whilst having a runny nose does not rule out COVID, it's more likely to just be a normal cold rather than COVID. 7 days after development of symptoms is when, unfortunately, some people will become unwell. And the way in which people become unwell is that they feel increasingly short of breath. So they might become short of breath when they're walking for short distances, or at rest, or when they're doing exercise. And a minority of those patients then, unfortunately, will need hospital admission for oxygen treatment. This paper here, you'll see on my slides, there is a link at the bottom of each one of the slides where you can download the paper I've used. This paper was taken from the UK. it's by a group called the International Severe Acute Respiratory Infection Consortium. And they recruited over 20,000 patients in the UK with COVID. And they looked at which symptoms they had. What are the most common symptoms? And you can see on the left there a long list of different types of symptoms. And you'll see on there that a runny nose is there, but it's very, very low down the list. The most common symptoms are cough, fever, and shortness of breath. Okay? And on the right-hand side is a Venn diagram, and you can see that that triad of symptoms, those three symptoms, were present in 7,465 of those 20,000. So that's about a third of patients have those symptoms. So those are the things really to look out for. If we can do imaging, it shows that there is just this diffuse, this bilateral shadowing in the lungs. So there's nothing very specific about chest x-rays for patients with COVID. Okay, it occurs across the lung. It's not particularly specific. So this could look like pulmonary edema sometimes. The chest x-rays aren't that helpful. CT scans can be more helpful, but in this context in Malawi, it's very, very difficult to get a CT scan. This CT was done in the States and was published in a New England journal. And it just generally shows that there are these bilateral ground glass opacities. So the shadowing is where bits of a lung have bled and it's become a problem. And they've infarcted, they have died. This figure is again from that paper I described, the 20,000 patients in the UK. And the investigators looked at the medical history and the background or the demographics of the patients who were being admitted to hospital. And it shows the hazard ratio or the risk of death according to different factors. Okay, and from this you can see that the biggest risk that patients have for dying is the elderly. Okay, so with each increase in decade, the risk goes up. And so the risk for people who are less than 50 is low. But as you get older and older, when you get to being over 80, the risk becomes very high. And in some ways, for the Malawi context, this is reassuring because the Malawian population is young. The median age in Malawi, I think, is below 20 still.
Yeah, 17.
Whereas the median age in the UK is above 40. And so there is a large number of young people in this country. But this highlights why we need to protect, we need to shield older people from COVID in Malawi. Being female is protective, so that's reassuring for females, unfortunately for me, but that is protective. But there is also a risk associated with having heart disease, lung disease, kidney disease, particularly obesity seems to be a problem. And having liver disease seems to be a big problem. So these are the factors which increase your risk. So essentially, if you're male and you're over 50 or 60 and you have heart disease, those are the patients we really need to be worried about. They're the ones that we as doctors will need to be very, very concerned about. This is a bit of a departure for me. It's qualitative work. This was published in the Lancet Global Health, and it's published from China, and it describes what the Chinese health professionals experienced when they first had to cope with looking after patients with COVID. And I think it's useful just to think through these things for what healthcare workers will be faced with in Malawi. And I think it really highlighted that PPE is vital, and I think the government and donors are doing very well in donating PPE. The most important component of which is your N95 masks. There is very little evidence for gumboots and for whole body suits like they were using in Ebola. There is evidence for visors, for masks, for gloves and for gowns. That reasonable work schedules are important. Everyone's going to be working very hard, and so it's really important to make sure that people have rest, otherwise people will burn out. I'll just skip down to psychological support. So people, health professionals, have this call to duty. They need to join the fight. It's part of being a doctor or a nurse or any health professional. That's why you're in this profession, because you feel a need to help patients. But you can become overwhelmed and exhausted, and it's really important to recognise that and to share these experiences and to be open about them, to get peer support. And then the other thing, of course, is training, to have sufficient training that you can do your jobs effectively. Okay, and hopefully this webinar is part of that training for some people. Right, treatment options. The first and most important treatment option is oxygen. Okay, and I'm not going to teach you to suck eggs by saying that oxygen is important to perfuse the tissues, but what I will talk about a little bit is about what's going on in the lungs. Now, I have an anaesthetic background, and one of the things we think about a lot in anaesthetics is something called hypopulmonary vasoconstriction. And this is a natural thing which happens, which is good in the lung. So if you have a bit of phlegm or spit in a part of your airway, no air can get down into that part of the airway. And so the lungs are very clever. They naturally constrict the blood supply to the areas where there is no oxygen getting in and divert that blood to places where oxygen is getting in. And that's fantastic. But in this disease, you have a generalized clotting in the lungs. And unfortunately, you start to develop pulmonary hypertension. And it happens acutely. And that puts a large amount of pressure on the right heart. And when the right heart is pumping really hard, it demands much more oxygen. And for patients who are older, who have heart disease, it can't get that oxygen because the arteries to the heart are narrowed, and it can promote cardiac collapse and death. However, if you give oxygen, then it generally allows the lungs to relax those capillaries, and it reduces the pulmonary hypertension. So it's really, really important to get oxygen into people because it reduces the stress on the right heart. One of the major challenges we've had is to think through how to titrate oxygen properly. Okay, so people think about the oxygen flow rates, and that is important, but it's also about the interface. So how you give the oxygen is important. And so we have nasal prongs which go into the nose, and nasal prongs are effective at low flows. So at 2 litres, that gives 24%. At 4 litres, it gives 28%. If you persist in increasing the flow rate through the nasal prongs, that does not necessarily mean that you'll get an increased amount of oxygen delivered to the patient. After 4 litres via nasal prongs, it's very important to move to a face mask, because a lot of patients who are breathless are breathing through their mouth. And so you need a full mask in order to give them the full amount of oxygen. So after 4 litres, go to a mask, okay? And then titrate your oxygen up in a standardized way. A 15-litre oxygen flow on a non-rebreathed mask gives 60% of oxygen. And what we should be aiming to do, whilst it's difficult, is we should be aiming to try titrate our oxygen to achieve a saturation of 94 to 96. So in summary, to prescribe oxygen properly, you need to know 3 things. You need to know the flow rate. You need to know the interface. Is it nasal prongs? Is it a mask? Is it a mask with a reservoir bag? And you need to know the saturations. So there's been a lot of excitement in the last few weeks after the reporting of the recovery trial. The recovery trial, as you'll be aware, is a multi-armed trial which is testing a number of drugs. The first 2 drugs have been reported, The first drug to report and that drug was stopped was hydroxychloroquine. So this trial demonstrated that there was no benefit of giving hydroxychloroquine for patients with acute disease. And so we should not be giving hydroxychloroquine for patients with COVID. More importantly, the study demonstrated that dexamethasone, a steroid, given at a dose of 6 milligrams once per day, significantly reduced mortality. So there's a four-paned figure here. So figure A is all participants, and it reduced mortality to a risk ratio of 0.83. What was important, however, is that when you split those patients into those that needed mechanical ventilation, the effect of dexamethasone was more profound. So for the very sickest patients, dexamethasone reduced mortality very, very highly. Dexamethasone also reduced mortality for patients who needed oxygen only. Okay, but for those patients who don't need oxygen, dexamethasone is probably, I say this probably, is probably harmful. And so that we should not be giving dexamethasone to those patients who don't need oxygen. So people in the community who think dexamethasone is going to be a cure for them, no, it should be reserved for patients who are admitted to hospital and who need oxygen. I think the last thing to say about this trial, that for the malaria context, where there is a very, very short supply of intensive care beds, I was very reassured by the fact that in patients who needed oxygen, the risk, for those patients on dexamethasone who required oxygen only, the risk of progression, of worsening to needing ventilation was significantly reduced. And so that dexamethasone seems to reduce the progression or the worsening of disease. So I think this has been a game changer. And from the clinicians I've spoken to at Queen's Hospital, they have really noticed that there does seem to be a change in the patients. There are risks associated with steroids. The biggest problem observed so far has been that blood sugars for patients who are diabetic and pre-diabetic can be very difficult to manage. The other risk is, of course, that it can cause gastrointestinal bleeding. And so we do have to be cautious about that, especially for patients who might also be concurrently taking aspirin. And so we need to think about the protection of their stomachs with drugs such as PPIs, things like omeprazole. The next thing I want to talk about is heparin. So from the pathogenesis, from the way that the disease affects us, we understand that people are getting sick because they're getting clot in their lungs. And that there is increasing evidence that giving heparin to patients with COVID reduces the progression of severe COVID. Okay, in high-income countries like the UK, every patient pretty much, unless they've got a contraindication, who's admitted to hospital and is sick is given heparin. Okay, and it's a standard of care in countries like the UK and the US. The reason why it's not a standard of care in Malawi is because it's so expensive. It's a very expensive drug to give. But for COVID, where we know how this disease is worsening, the hospital in Blantyre especially has made funds available in order to purchase heparin. And so we are currently using heparin to prevent progression. Okay, there is research underway with this to test whether full anticoagulation can reduce the risk of death. Those trials aren't reported yet. And so the ideal drug is to give a low molecular weight heparin, such as enoxaparin. There are other drugs such as dalteparin, and to give that as a prophylactic dose, so as a low dose, and to give that once per day. Experience from my colleagues in the UK is that being generous with the dose of heparin is a good idea, because it seems to be, for some reason, less effective in COVID compared to your average patient. Okay, I'm not going to go into the details of that, but we can talk about it if anyone has any specific questions about it later. So as I say, enoxaparin low molecular weight heparin is ideal, but if not, unfractionated heparin can be used. So this is a heparin that we normally give intravenously as treatment dose. It can be given subcutaneously, but it has to be given twice per day. Antibiotics. So this infographic is taken from the WHO, and are antibiotics effective in preventing and treating coronavirus? The answer is no. But why do we give it? Why do we give antibiotics? We give antibiotics to people with severe disease because there is a risk that they can develop a secondary bacterial infection. And if they're already sick from a viral disease and then they get a bacteria on top, then that can be life-threatening and potentially life-ending. So we're giving the antibiotics not to treat the virus, but to prevent the risk of getting another infection on top. Okay? There is a lot of interest around certain antibiotic classes. For example, macrolides. Of macrolides, you will be familiar with azithromycin and erythromycin and clarithromycin. Those drugs, people are interested in those drugs because, as well as their antibiotic effect, they also seem to have an immune effect where they reduce the activity of cells such as macrophages. And as I showed you before, macrophages, overactivation of macrophages seems to be part of the problem in COVID. But that's a hypothesis. That is, there's no evidence for that yet. Okay, so there's a lot of interest in giving those antibiotics, but there's no evidence that they are better or worse than any other antibiotics currently. And I'll just say that it's best to stick with the currently protocolized antibiotics which hospitals are currently using. And so that means that for patients hospitalized with COVID, it's usually better to stick with antibiotics such as ceftriaxone. Pruning. So pruning means sitting or lying on your front. Okay, and this is something that we do commonly in intensive care for patients with very severe pneumonia. And as I said before, the blood pressure in your lungs is normally low, and so that means that the blood is affected very strongly by gravity. And so when you're sitting up, most of the blood in your lungs is at the bottom, and when you're lying down, most of the blood in your lungs is at your back. In pneumonia, what happens is the secretions and the spit and the sputum tends to sit at the back of your lungs, so that whilst the little air is getting into the back of your lungs, all the blood is there. And so you get this thing called shunt, where the blood goes past those alveoli, but because no oxygen is getting in, they don't carry oxygen. And so the idea of going on your front is that it diverts the blood to the areas of the lung which are less diseased, and that can help to improve oxygenation. And so in COVID, what we've been doing and what's been happening in the UK is that for patients on oxygen, we've been asking them to lie on their side and then on their front in a comfortable position for up to 2 hours. So on their right side up for 2 hours, on their front for up to 2 hours, and then on their left side for up to 2 hours, and keep turning around for as long and staying in the same position for as long as is comfortable. And that can help to divert the blood to areas of the lungs which are less diseased. And for patients who are very sick and needing a lot of oxygen, this seems to be helpful so far. It's also a source of chest physio. It helps to remove, or it helps to clear some of the secretions. Last two slides. We're getting into intensive care treatment territory now. One of the things which has been used in a lot of countries in Europe and in the UK has been something called CPAP. CPAP means continuous positive airways pressure, and essentially it's a very tightly fitting mask with high flows of oxygen. And essentially what that does is it forces the oxygen into your lungs, and it splints your lungs open. And it's quite unpleasant. It feels like you're in a wind tunnel. So it's not a very nice thing to have done to you, but it does, for some patients, increase the amount of oxygen that gets into their bloodstream. The risk of that wind tunnel is that it can blow COVID everywhere. Okay, and so there's a risk to the healthcare workers who are looking after these patients. So it should not be done unless there is adequate PPE available for staff. And it shouldn't be done on open wards. It should be done in isolated areas, isolated rooms, ideally with negative pressure to suck out that horrible virus. The negative pressure thing in Malawi is very difficult. I don't know of a negative pressure room in Malawi. And what it does, it recruits those alveoli. So it opens those alveoli up and it can improve hypoxia. And it might, and I say this might, it might avoid the need for intubation for very, very sick patients. I started this slide with the word controversial. I can't hand on heart recommend this treatment. It might work, it might not work. It's an option, and when your back is to the wall and a patient's very sick, it's something that you might wish to try. But I don't think there is strong enough evidence to say yet that it does save lives. It could do, and so it's something that a lot of people, I'm sure, will be looking to try. Ventilation. Now, when COVID first came to Malawi, there was a huge amount of emphasis on buying lots of ventilators for patients. And I'm an intensive care doctor, and in the UK, I use ventilators all the time. In Malawi, the number of intensive care beds is very low. Being on a ventilator, though, isn't just about being on a ventilator. It's about everything else. A patient on a ventilator needs one-to-one nursing care, so they need their own nurse for 24 hours a day. And a nurse can't work 24 hours a day, and a nurse needs to have time off. So one ventilator really means that there needs to be at least 3 or 3.5 nurses per patient looking after them. And in Malawi, there just isn't that many trained nurses to look after ventilated patients. And so being put on a ventilator for COVID in the Malawian context, I think, is going to be very, very difficult and challenging. And I've put this slide up there just to say that it is an option, but it's something that is going to be very challenging to actually do in the Malawi context. And that is the end of my slides and Titus's slides. Peter, I'm afraid, hasn't been able to join us. So at this stage, I apologize that we've not been able to give the whole of the presentation, but if anyone had questions in relation to either Titus's or my section of the presentation, then we're very happy to try to answer them. So if you have a question, please raise your hand, or you can send a message to the group. There's a question now already. Is it possible to access the slides? Yes, I'm happy to provide the slides. We will think about the best way of doing that, and we'll probably advertise on Twitter.
Yeah, Twitter will do, yeah. Twitter and Facebook, yeah. We'll share a link and then you can download the slides on your own.
Okay, Ben, there is another question from Andreas there on the chat, if you can see.
Yes, we can see that. The question is, what is your sense about the anticipated increase in patients requiring admission? Yeah, my sense is that there is increasing numbers of patients requiring admission. I think there was hope in Africa that we might be less affected until recently, but I'm certainly myself quite anxious looking at what's happening in South Africa right now. I think that we are still at the start of this. I am anxious that it's going to get worse. I can't be more hopeful than that. I think we just need to keep doing what we're doing, distancing, wearing masks. As Titus said, I'm very driving around Blantyre. I am very reassured that the number of people are wearing masks, and we need to encourage that.
Yeah.
And importantly, we need to shield those patients who are at high risk. We have a hand up from Cynthia. Cynthia, do you want to ask your question?
Hi, hello, thank you. Thank you for the beautiful presentations from the both of you, quite informative and insightful. I actually have a couple of questions, a few to Titus. So I wanted to find out who is in the national task force. I think you called it the National Disaster Preparedness and Relief Committee, the structure that is just below the Presidential Task Force. I asked this question because I understand the composition of the Presidential Task Force, where there are a lot of ministers in there, and a few people who actually have the technical knowledge and expertise to provide guidance on the issue of COVID. So I would like to understand the composition of the structure below it and see if it is a structure that is actually offering advisory support to the Presidential Task Force. And then secondly, one of the things that you mentioned, Titus, is the fact that the downward level structures, the district structures haven't been utilized. They haven't been active as yet in the response to COVID. Do you have a sense of the plans that are in place to ensure that the structures, the fight against COVID-19 in Malawi? And then added to that as a segue, to what extent is the government of Malawi utilizing structures that were actually put in place to respond to HIV? Because I think we actually have a robust network of structures at community level that that continue to play an active role in the fight against HIV. And then lastly, are there any projections of where Malawi will be in terms of the cases, the epidemiology of it? And are we using these projections to inform our planning? And I know that at the very beginning of COVID, there were a number of models that came up, but have those models been updated? And are we using them to do our planning? Thank you. Sorry, the last question was to the second presenter. So one of the things that you said was with ventilators, you probably need about two or three nurses. But we've seen from other countries that a lot of people have actually ended up in ventilators. And I understand that in Malawi we don't have enough bed capacity in ICU. We don't even have enough ventilators. So what's the plan for us? Because looking at the trajectory of COVID and what has happened in other countries, it is most likely that we'll have a lot of people, a substantial amount of people, even though the percentage is quite small, but a substantial amount in ICU needing ventilators. So is there a plan in place to meet that?
Thank you for those questions, Cynthia. Regarding the structure below the Presidential Task Force, let me confirm that it's all technocrats from the ministries involved in the clusters. It is not politicians. Our politicians are in the task force. Indeed, the task force is full of politicians, except one individual or two. But hopefully that gives us a political will. And the structures below the district level, it has also been a huge concern for myself. We haven't utilized community structures as much. I take COVID-19 as more of a community than a facility disease, because there's a lot you can do at a community to prevent people from going upwards in the disease progression. For example, the shielding of the elderly to make sure that we protect them from catching the disease. All the prevention measures we're talking about, the masks and all, happen and have to be implemented in the community. So it is my hope that where we're going with the understanding of moving forward with the disease, as well as coexisting, rather, I should say, with the disease, we will invest more in the community level. But of course, I cannot speak for the government. The other question, in your other comment, you mentioned we haven't learned much from HIV. Indeed, HIV is one of the diseases where Malawi has been a champion globally. Countries come here to learn about managing HIV, and community structures pushed us a lot in that direction. So I know the ministry has been taking interest, asking HIV experts how they managed the epidemic at the beginning. So maybe we are going in that direction now. And then you asked about projections for Malawi. There are various assessments being done. Peter's presentation would have been more insightful on this particular aspect. The original projections put us at a much faster spread and much higher number of hospital admissions and deaths than we're having now. So we are having either two scenarios. Either our epidemic is slow, as Ben also alluded to earlier, or our epidemic is less disastrous. So to have a tie, you need to do a little bit more detailed work to understand how many have gone through the disease already. So several surveys, surveys that test people to see whether they've had the disease or not, are currently being commissioned to see what proportion of the population has had the disease, and see whether we have had a lot of mortality, because that's what can help as well. If we know how many people have had the disease already, and we also know how many have already have died, whether of COVID or other illnesses, compare that this year to previous years, that can tell us whether the epidemic has been as disastrous or not, depending on the stage where it is now versus other countries. So a little bit more cautious in my response, because we don't have a very clear idea yet at this particular point. Over to you, Ben.
So the final question was around intensive care provision. So I think that there has been some increase in the numbers of ventilators available, but the numbers are still low. And the numbers of intensive care beds per patient or per population in Malawi is extremely low. And worryingly, it takes a good 6 months to train an intensive care nurse to be able to look after a ventilator effectively. So in answer to your question, what are we going to do? My advice would be that when people feel breathless, they should be trying to get into hospital earlier. If you feel that you've got chinfini, then stay at home. But if you start to feel breathless at home, whereas you are getting breathless when you're walking, when you normally don't, then that would be the trigger for me that I think you should be starting to present to hospital. And if you can present early, then that means that you will hopefully be in a less severe stage of a disease, and that by starting the drugs like dexamethasone and heparin, we might be able to prevent worsening. But it's very difficult for me to be much more optimistic than that, because it's something which is common across all lower and middle income countries, that the intensive care provision isn't there. There is limited resources for health in low income countries, and those resources are better spent in public health, in prevention. And so, as Titus alluded to, we should be really focusing on trying to prevent those people who are at risk from getting this disease. That's where our focus should be. Okay, I'm going to move down the list. And onto P. Sackett. You mentioned the aging profile in Malawi is potentially very beneficial. Any other thoughts on other contextual issues in the Malawian population, e.g. levels of nutrition or prevalence of HIV?
Thank you for that question. The other non-risk factors will most likely be applicable to Malawi, which we already discussed. These include chronic illnesses such as diabetes, hypertension, chronic lung disease, other chronic heart diseases. I don't have much knowledge about the role of nutrition, but Ben may add. But where evidence from South Africa is showing that HIV is becoming more and more of an important factor. So my advice really is that all people with chronic illnesses should make sure that they are taking their medications consistently and they are keeping healthy as much as possible. That way, the disease will, if it finds them, it will find them healthy. But also remember that these are the people we are recommending shielding for. Shielding simply means observing all prevention mechanisms very seriously, i.e. staying at home as much as possible. And whoever is living with these people who have risk factors for severe disease and death should make sure that they also limit their movements, and they should also limit their, if their movements are increasing, they should also limit their contact with this particular individual. That way we can improve our chances of losing a lot of people. So the next question is, how is Malawi generally performing? What is your comment on the number of deaths we are seeing in Malawi?
It's difficult to comment, is my answer to that. I think the numbers of deaths are low. The numbers of cases are low, but we know that there will be a lot of tests which perhaps might have been done in a higher income country that haven't been able to be done here. And so it's very difficult to know how Malawi is doing because we don't have as much epidemiological information as we would wish to have. And so it's very difficult to speculate. And to be honest, I can't give an answer to that. I don't know what you think, Titus.
Yeah, so it's usually easier if you have followed the epidemic numbers in more detail. So key really has been who are we testing and how much are we testing. So our testing now, if the numbers that you see, as I mentioned in one of the slides, are only based on travelers, contacts of those who test positive out of that population, and some high-risk groups like healthcare workers, as well as those who are severely ill. So those are the numbers that you see the presidential committee announcing every day. They are based mainly around these populations, which doesn't give you a full picture of the epidemic. However, our current understanding now is that we have reached community transmission stage, where spread is much higher than it was at the beginning. So in terms of interventions, you can only tell whether interventions are working or not if you consistently follow those numbers in a more systematic way than we have. I have hope that in the near future we'll be able to follow because some researchers are rising up and doing some really interesting studies that will help us track where we are better than we have been. So that's critical, yeah.
There are 3 hands raised. I don't know if you have noticed.
Okay.
Yeah. We were going to just scroll through the comments, if that's okay. So Chaponda Mas has made a comment. Comment noted. is there an increased risk for people who are over 50 in Malawi? I think that does hold true for Malawi. So the deaths that I've been aware of in Malawi have been for those patients who are older. I think the South African lessons to be learnt are interesting, that it seems to be affecting maybe a decade younger in South Africa.
It is younger,
than it is here, than it was in the UK.
Yeah.
And that might be because life expectancy in South Africa, Malawi is lower than in higher income countries. The life expectancy in Malawi, median age is about 65, 66, whereas in the UK it's about 82. And what I take from that, I'm not a public health doctor, but what I take from that is that people in Malawi live with chronic illness from an earlier age, and so they might be affected by chronic illness at a younger age potentially than in the UK. And so it might be that it's from the age of 40 in Malawi would be what I anticipate might be the problem. Yeah?
It's a possible explanation, yeah.
Maybe. I don't know. We'll have to see how it pans out. It's very important, as Titus said, to collect data and to understand those patients who are admitted to hospital in order to understand this disease better in our context. So Nematoto, on average, how long do patients with COVID stay in hospital, and are we seeing the same presentation of the condition as we are or were in the UK? I can't give you an average. What I can say is that patients need oxygen for a prolonged amount of time. The patients that have been looked after, that I'm aware of, have needed oxygen for more than a week, and the oxygen has been titrated down gradually in order to come off, and it's taken a little while to come off oxygen for those patients. So when patients are admitted, they do need prolonged admissions. Are we seeing the same presentation of the condition? The patients that I'm aware of, I would say yes. There's this idea of happy hypoxia, which has come from the UK, where a patient can present with very, very low oxygen saturations, but actually feel okay. And I think that that's why I'm being very hopefully clear with you that for people who are 7 days after the onset of their symptoms might have gone, the tiredness and the kind of muscle aches and pains, that might have settled. But if you are starting to feel short of breath on exertion, so when you're walking or when you're doing things, then that would be worrying to me. And I think you shouldn't be reassured that your symptoms are better if you have started to become short of breath. It's shortness of breath that is the worrying thing for me.
Maybe we can take one hand.
Yeah, let's take a hand. So we've got 3 hands. We've got Cynthia.
We had
I
Cynthia
think
already.
we've had Cynthia. So we've got Vela now. Vela?
Yeah, thanks, Dr. Divala and Dr. Morton for your presentation. My question is I have 2 questions. Dr. Divala, on National Task Force, do you have any plans or are you doing it already, like visiting these isolation wards and appreciate the work they are doing and also maybe provide support? I'll give an example of Queens, where there's a ward which is not yet opened, oxygen, it has oxygen pipes and everything, but due to maybe other constraints like resources, they're failing to open the ward. So the Presidential Task Force or the National Task Force, are you visiting these sites to support them that they can provide the much needed care which the COVID patients needs now, but it's not being provided because of such difficulties? The other question to Ben, how much difficulties are you facing managing people with comorbidities like underlying problems? If maybe a maternal case has COVID, how are these being managed, or maybe any other underlying conditions? Are you facing such problems or admitting them in these wards? Because what is observed is maybe other tests or other investigations are sort of like you put aside and we are just concentrating on the COVID. So how much difficulties are you facing this in managing such cases? Thank you.
Thank you. I'll take the first question and I'll leave the second one to Ben. So the task force, I'm not in the task force, but I'm aware that the task force has been visiting isolation centers. I was informed earlier today that the minister is actually going to visit Nzuzo and Karonga isolation centers today or tomorrow, and she is also coming to visit Queen Elizabeth. Also, is it this week? Sometime this week.
I'm not sure.
Yeah. So they do visit, and hopefully, when they visit, those issues will be channeled to them for action. And the second question you asked on how we are managing those with underlying diseases, especially pregnancy. Are we getting all resources? Yeah.
That's a very difficult question, Vela. So clearly, COVID is something that can affect pregnant women. Being pregnant does not seem to increase your risk of death compared to not being pregnant. And obviously the age of being pregnant is young, so if you less than 50, and obviously it's females. And so there are positives to be said that the risk of death to people who are pregnant if they contract COVID is low. I think there still needs to be more work done in terms of how it affects the unborn child. And I'm not an obstetrician, and I don't feel comfortable to speculate on that because I don't know, honestly. But I think the wider point of patients do present with underlying diseases, and the management of those underlying diseases is very important, both before people get COVID, so people need to be accessing the treatments that they normally take and to take them routinely. But when they do have COVID, they need to continue those medications. And doctors, when patients are admitted to hospital with COVID, will have to manage COVID and other comorbidities. And that is a challenge. One of the challenges that's being observed currently is with diabetes and COVID, whereas it's very difficult to control patients' blood sugars with COVID. That's not helped by them receiving steroids, which are known to put up blood sugars. And so doctors and nurses have to be very careful and cautious and mindful and think outside of the box with COVID. It's not just about oxygen. You also have to look at the whole patient and treat the patient in a very systematic, standardized way to appreciate how COVID can impact upon their other diseases. Hopefully that's helpful. And it's quite vague, but I don't have a specific answer on pregnancy.
Remy?
Whilst we're waiting for Remy, we'll go back to the comments.
The chat. Remy, if you can hear us, you can ask your question now.
Yeah, thank you, Doctor.
May we all put our mics on mute except one person who is speaking.
Yeah, thank you for the wonderful presentations. My question basically is touching on the effect of dexamethasone. Before I got admitted at Queen's, I had no problem with sugar levels. So they started administering dexamethasone, and heparin. After some time, they noted that my blood sugar levels were just going so high. So a decision had to be made, and they had to stop administering dexamethasone. Now, I think I spent 4 more days, but after they had stopped dexamethasone, and the blood sugar levels were still acting up. Up to the time I was being discharged, I was given lente and metformin, which I'm still using up to now. I think I was discharged on Sunday. Now my question is this thing now permanent, or there will be a time when I have to get back to my normal life and stop using lente and metformin? That's where my question is. Because when I was leaving hospital, no one was clear on the aftermath. Yeah.
Okay. Remy, can I ask you, were you a known diabetic before you were admitted to hospital? Were you on treatment for diabetes before you came in?
I was non-diabetic before going into hospital.
Okay. So two things to say, Remy. I'm very glad that you've got better.
Remy, may you mute your mic, and also anyone whose mic is on? Yeah.
Okay, I'm going to try again. That's better. Okay, so Remy, two things. Having any severe acute illness, be it COVID or anything else, causes your blood sugars to rise. Dexamethasone and steroids are very well known to cause your blood sugars to rise. And so the side effect that you unfortunately experienced is very common. And the doctors made the decision. It sounds like it was probably the right decision, because you've improved and you have been able to go home, to stop your dexamethasone early, and that's fine. In the study, just for everybody else, in the study, the recommended length of course was 10 days, but if you look at the study, most patients only received 6 days. Probably because of some of the side effects that Remy has described. Steroids hang around in your system for a while, and so the blood sugars being high might persist for a little while. It's important, Remy, that you see a doctor to be followed up about your diabetes, to make sure that your blood sugars do come under control. What I would suggest is that over time, your blood sugars will come back to how they were. And hopefully, once you are completely over your illness, it will take you a few weeks. But when you're over your illness, your diabetes control will go back to how it was before. But when you've had such a severe illness and you've had the steroids, it's very common that your blood sugar is poorly controlled for some days and weeks afterwards. Is that okay? I think it's very important that you see a doctor to monitor your blood sugars, to make sure that your blood sugars don't go too low. Remy, does that answer your question?
Yes, thanks so much. It does answer my question.
Okay, thank you. Great. We've got 3 hands up. We've still got Vela. We think Vela's done. We think Remy's done. We've got one from Vitambiku Gubuduza.
Thank you, and thank you for the wonderful presentation. I think it was very clear. I've got one question. There have been reports that you can have, I think there have been cases where some patients have had a positive result for COVID for 3 months. There are cases where the symptoms are still being experienced by the patient. I've noticed that not much has been said about that. And also I'm concerned with, I think, the recent decision by the government that they will not, I think after a certain time, is it 14 days or 21 days, they will consider a patient to be okay. And then they have, I think we've seen the increase in numbers of patients that have been healed or they are considered okay. My question is, what would be your comment about that? And also, what do we need to know about the long-term effects of the disease? Thank you.
Yeah, I'll attempt on the side of prolonged positivity. It's indeed something that's not uncommon for a COVID-19 patient to remain positive for some time. Some going beyond day 28 of follow-up. But the reason the guidelines have changed here in Malawi, actually internationally, starting with the World Health Organization, is that the infectiousness, the ability of someone to infect another person beyond having 10 days without symptoms, or 10 symptomatic days and three asymptomatic days thereafter, that at that particular point in time, your chances of infecting other people are very low. And if you are well at that particular point, it is okay to be declared COVID-19 free. So that's the current approach, and it is backed by that kind of understanding. On the other part, Ben, do you want to come in?
Yeah, just on that. So it's when you do a COVID test, what you're testing for is RNA, and the RNA doesn't tell you whether the virus is alive or whether it's dead. And the viral RNA can hang around for up to 3 months. And so it might be in your cells for a very long time, but that's just dead virus. And so doing repeated tests on people when they are well can cause problems in of itself, because if they remain positive, then you've got to do another test and another test and another test, and that can have a massive psychological effect on patients, a negative psychological effect. Whereas in actual fact, if you actually look at the patient, they are better, they don't pose a risk to other people, and so doing a test, all you're doing is you're proving that there is still dead virus in the patient's body, which doesn't help anybody, and it doesn't help the government because it doesn't tell you anything. The patient isn't now a risk to other patients, and it's part of stigma as well. Is really important that 10 days, as Titus said, after the symptoms start, you are no longer infected. You might have had COVID, but it's very important that you aren't stigmatized, and needing a negative test in order to be declared COVID-free. And for some patients who have repeated positive tests, that can be very stigmatizing. It can be very disruptive for their family and for their life and for their mental health. And it's not needed.
Yeah, so just to say that the benefit of having a test in itself is that once you test positive, you do your best not to infect others. Once you test negative, but you are being suspected of having the disease based on the fact that you are a contact of someone, the understanding is that you should also remain as careful as possible because you may have the disease. But after the waiting period has gone, say 10 days in the new guidelines, the chances of you posing harm to others is gone. Therefore, there's no need to worry beyond that particular point. But of course, to maintain the general population level controls, wearing masks and all the other measures.
Yeah. And your second point about persistent symptoms, unfortunately, and we will learn more about this as time goes on, it does appear that for a subset of patients after COVID, they do have persistent problems where they have having long-term fatigue is common, having long-term shortness of breathness sometimes happens, unfortunately. And this isn't due to continued infection, but it's due to the fact that the patient has suffered a very serious insult to their body. And it can take a long time to get over a critical illness. So when I have patients on my critical care unit, this is away from COVID, someone is very sick, I will tell the family it can take 3 to 6 months to get back to normal. And so when you've had a very severe illness, and COVID for some people can be very severe, it can take a very long time to get back to normal. And right now, because it's such a new disease, we don't understand enough about the long-term effects of COVID. And that's a very important thing that needs to be researched in the future.
Kuzwaya?
Yeah, thanks for your beautiful presentations. I just wanted to find out, Lile, in terms of testing. My understanding is the government doesn't have enough kits at the moment. I think I saw a briefing from the health minister saying that they've received about 38,000, which to me I think is not enough. So what would be your suggestion? Do you think they should continue with the approach of testing even the contacts of the index cases? That's the first question. The second one is with the injunction that was granted by the court. Do you know if there are any plans for this maybe to be lifted? You might not have an answer, but the fact that you're in contact most of the time with the Minister of Health and the government, probably you can shed more light on that. Thank you.
Oh, sorry, Kuzwaya, may you come again on the second bit? The what's it? Yeah.
Yeah. So I'm just worried. Yeah, I'm just worried with this injunction, which is still there. Are there any plans now for it maybe to be lifted? Because I can imagine that I think that's going to pose a serious challenge in managing this pandemic in Malawi if it's still there.
Thank you for your questions, Dr. Jerry. The testing strategy. So at the very beginning of the epidemic, it is very important to extinguish the fire as it is rising. You want to test everyone and catch every case as much as possible. Now, when we have a lot of cases, the most important thing is for us, the population, to do our best to stay home whenever we go out, to wear masks, to ensure that we don't pass on. If we have the virus, we don't pass it on. If someone has the virus, they shouldn't pass on to us. So where we are, I would say, yes, we don't have enough test kits, and that takes away one of the important weapons for fighting COVID-19. But not all hope is lost, because if we, the population, start following these simple measures of making sure that we don't pass to others or others don't pass to us, ensuring that we stay home, especially when we develop symptoms, the whole house stays home as much as possible until the quarantine period, which is 10 days, is over. But even if at that particular point you go out and you're already in your mask, you're always washing hands, you're not touching your eyes, you're following all that, then we still have our grip on population level control of the disease. So I was starting to say testing is critical when you want to extinguish the fire quickly. So that's at the very beginning of the epidemic, and at the end when you just want to get it over and done with. In the middle, it relies on what the people are doing. If we are careful as the people of Malawi, then we'll go through this easier. If we are not following the measures, it may be a little bit difficult, even for the government. On the issue of the lockdown, so my understanding is that the case is going back to court. It moved from being an injunction, now it has become a constitutional issue. So the hearing may start in 10 days' time. The government, through the Ministry of Health, is doing also its best to be part of the case through the Attorney General and advise the court on what is the best direction. Thank you. Ben, do you want to add anything? Okay.
No, I don't think I can add anything to that, Titus. So we don't have any more hands up currently, so I'm just going to scroll through the questions.
And just to say, if you have symptoms and they are mild, don't panic if you fail to access a test. It is not really time for you to panic. It is time for you to isolate at home and just make sure that you stay without, you follow your symptoms. If they're getting severe, you run to you call the usual phone numbers so that you are taken to the health facility at that particular point. If you don't get there, don't worry. Then you go through the 10 days and you'll be fine.
Yeah. And the most important symptom to watch out for is shortness of breath. Okay, so Lucky guessed. Ben, what are the demographics for reported deaths so far? I think we've talked about that since, I hope.
Yeah.
So Titus.
So you're saying you still have questions on modalities of shielding the elderly, especially with stigma we have towards the age group. And you mentioned, you said, I mentioned that there's surveys currently to measure the actual cases on the ground, who is doing this. So on the second question, the Public Health Institute is doing a survey very soon. The Malawi Livable Wellcome Trust has also been working very hard, and they will be publishing their results very soon. They have already shared with the Ministry of Health, and the Ministry of Health is already working to act on that. Once they are public, all of you will have access to those results. So there has been some work on determining the current status of the epidemic. Regarding modalities of shielding, it really has to be something that is led by the community. It is not something that you can impose on the community and expect it to be done. So my thinking with a group of investigators from the College of Medicine, Malawi Livable Wellcome Trust, and the Society of Medical Doctors, so far we have been thinking of an approach where, imagine in your home village where there should be 5 or 6 families where people are related. And in those families, during the time when COVID transmission is very high, what could happen is that individuals who are aged 60 and above, or in this case, maybe we should be thinking of 50 and above, move into one house, and then the rest of the individuals shift around. In that one house, there's someone who is taking care of them, and the 5 houses essentially contribute to support that particular house. Stigma, yes, stigma is always there, but if this is community-led, if you come to the community, give the advice, and let the community make decisions, we need to start thinking of the older adults as our pillars. If you approach it that way, and with our Ubuntu philosophy, I think we can get around it. These are times for extraordinary measures, so everyone needs to think outside the box. But key for shielding is not top-down, it is bottom-up. You have to sensitize the community and let the community make a village plan for managing COVID-19 in general, a village plan for shielding all those that are at risk. First step is to identify them. Second step is to make provisions for shielding them. So village-led, it will work.
We have a hand up from Chaponda Mas.
Hi, thanks for your excellent presentation, both of you. More of a comment, but also a difficult one, and that is how long after you've had COVID do you remain immune? And I mean difficult because when can you get reinfection? I think at the moment we're debating between 3 months to up to a year.
Titus, neither Titus and I are immunologists.
Is Kondwani here?
Is Kondwani here?
He was. I'm not sure if he's still with us.
Okay, what I will say is that there's been a lot of publications recently around and concentration on the whether or not antibodies are present or not. And the degradation of antibodies or the loss of antibodies from the system has been reported extensively, and that the antibodies don't hang around in the body for too long. And especially if you have a mild infection, your antibody response can be low and your antibodies might not be around for very long. But that's not how immunology works, as immunologists here will be able to tell better than me. You do get memory cells and your immune system does remember the virus. But I don't think it's clear yet in any of the literature how reinfection and the T-cell mediated immunity works in COVID-19. I am optimistic that a lot of those answers will be gained or gleaned through the vaccine trials which are currently underway. You'll have seen this week in the Lancet that there was a phase 2 trial published from the Oxford vaccine. I think there's almost 20 different vaccines which are under development. The Oxford vaccine is the most far advanced vaccine, and by advanced I mean it's into phase 3 trials, which is the immediate trial before the vaccine could be potentially used. And that those patients are being recruited right now in England, and I believe it's been extended to both South Africa and Brazil. And so I think you ask a difficult question, and I'm going to say there isn't an answer, but it should become clear as time goes by.
Thank you.
So the other question is from Tinashe. Can you comment on why the number of deaths are higher in Blantyre compared to other regions of Malawi? Thank you for that question. There may be a lot of factors. It might be that the epidemic in Blantyre is ahead of the epidemic in other areas, or it might be that Blantyre is reporting better than other parts of the country. So no clear answer, but yeah, one of the possibilities is that because the epidemic in Blantyre has had a lot of the southern part of Malawi is where most of our citizens who are returning from South Africa were arriving into, and some of them were coming and being managed in Blantyre. So that's one possibility, because during that time, it was also at a time when the positivity rate, when they were coming in, was very high, and we did not do a very good job of managing them during that particular time. So that's one part. That's what can put the Blantyre epidemic a little bit ahead. But I would say it may not be the only reason. So there's no clear answer really. Thank you. So
there's an go on.
So Tionge is asking Ben, if you happen to have 3 critically ill patients, a nurse, a pregnant woman, and a politician who needs a ventilator, with limited access to the which one will you give priority?
Can we ask whoever's mics are on just to mute? That is an incredibly difficult question, and not one that I would feel comfortable giving an answer to in isolation. As an intensive care doctor in England, I am often faced with more patients than I have ventilators for in England, which is a high-income country where there is lots of, well, compared to Europe and compared to the US, the UK has many less ventilators. We don't have as many ventilators. So I'm used to having to make difficult decisions about admitting patients to intensive care for ventilation. The question you posed, though, is an incredibly difficult question. And in this context, as a non-Malawian who doesn't work currently on the intensive care at Queen's, I don't feel that it would be for me to make that decision. I think it would have to be a decision which is made with ethicists, if there is time, and as a group. So I don't think there's an answer or an easy answer to that question. Sorry.
Thank you, Ben. And then there's another question, a comment rather than a question. The Minister of Health, together with Kunika, have developed a suite of digital health and data integration tools for COVID-19. If used properly, these would provide extremely valuable real-time data. Yeah. So thank you for that comment. And then let's go to the next question. So this is Edward. You joined late and you're asking whether we're going to share the recording. We will share online via Twitter and Facebook. Probably how you got the link to this meeting. So we'll do the same so that everyone has access to the presentation. Can you say something on the infectivity of the symptomatic versus non-symptomatic? Do you want to answer that, Ben?
So it's slightly outside of my expertise. I would feel more comfortable if Peter were answering that question. My understanding is that the more symptomatic you are, the more infectious you are. It kind of makes sense. If you're coughing, you're more likely to spread the droplets and the aerosolization of the COVID virus. And I think that is my understanding. But there will be better people, other more expert people able to comment on that in more detail.
Another question is it very likely that Blantyre and Lilongwe were simply ahead, as that they were much more intensive and consistent seeding? We've talked about that.
I think the other thing to say about that, though, is that they are major cities, and if you look at conurbations, if you look at the UK story, because people live more closely together and it's much more difficult to distance in a city, you are more likely to see higher numbers of cases and transmission in a city compared to what you would see in a rural community.
And then the other question is, are there plans to ask general public to volunteer other duties in the fight against COVID-19, which do not require medical training, to help overstretched medical personnel? This is a very good suggestion, and I would really hope we could do that. We can pass the suggestion to folks in the Ministry of Health to see if they can go for it. Will you share the absent speaker slides too? Yes, we will share all the slides. In patients admitted to Queen Elizabeth, with COVID-19, what has been the pattern of cardiovascular effects of COVID that you have experienced, if any? Acute, peri or myocarditis, acute ischemic events.
So yeah, I don't know. It's a short answer. I can't give an answer to that. I don't know.
So yeah, the other question is about the critical role of oxygen treatment, and only Queen Elizabeth has it. That's an important point, and I'm sure the government recently has been talking about having another plant in Lilongwe, so that's positive. And the last question. Where is it? Can you summarize the current guidelines for quarantine, for direct contacts and isolation for non-hospitalized cases? So I would say they both look the same, both quarantine and isolation. But the key is that in isolation, you're looking out for symptoms that will make you quickly get treatment. You're looking for breathlessness and other symptoms. In quarantine, you are looking for symptoms to see if you need a test eventually. And the duration, at the beginning, it was always 14 days for both, and if you're aware at that particular point, then you are discharged. Now it's been reduced slightly to 10 days or 10 plus 3 days. So I would say take the advice directly from the person who has tested you or has asked you to go into quarantine. So it's either 10 or 10 plus 3 days. Thank you all for the time we have had. We apologize again for the difficult start that we had. We would like to end the meeting now, and hope that if we call again for another presentation of this nature, we'll meet again. And just look out for our Twitter pages as well as our Facebook pages to catch the slides as well as the recording if we're able to upload it as well. Thank you. Okay.
Thank you very much, everyone, for listening. Very grateful to be able to help if it has been helpful. Thank you and goodbye.